everybody. I see a lot of familiar faces, so I'm sending my greetings and my hugs virtually to everybody who's joining us today. And thanks so much for being here. So the Cure Forum 2021 is a reboot of one that we started in 2019. And at that time, our introduction said something like this: there are 35 million adults in the United States providing unpaid care to loved ones. Could be childcare, elder care, and then of course, most importantly, self-care. So today's talk on the care recipient and the caregiver is going to focus on that relationship as a unit of care and what that means. Now, our speakers have asked me to give a brief intro because we want to just jump right into this. So they are both pioneers in elder care. Dr. Ellen Brown is a pioneer in the hospice movement, has served thousands of people in our area dealing with difficult end-of-life conversations, helping families to assess their values and their treatment options. She's the former medical director of Pathways, and psychologist Dr. Rita Ghatak has also pioneered aging and elder care services in our area. She was the director of the Stanford Aging and Adult Services Program, where she and I first met because I was a discharge planning social worker there, and we would just be like, passing each other in the halls frequently. And now she is the director and founder of Aging 101, which is an elder care consulting service, a research service. And Rita is very involved in looking at caregiving on a very high level for a lot of research initiatives and also a book project. So Ellen and Rita, I hand this over to you and I'll come back on during certain moments. Thank you.
Thank you, Paula. Good morning, everybody. Welcome to the second session of Care Forum 2021. We are so grateful to the Avenidas management team, Wolfson and Kat King for your help today. Dr. Ellen Brown and I have continued to work very closely with caregivers and families through the pandemic. And today, we wanted to discuss a very important topic of recognizing the caregiver and the patient as a valid unit of care. Now, why is this important? Unless we look at the two of them as this unit of care, we may not be able to help with many aspects of patient care, patient health navigation, and to help the millions of informal caregivers. We hope that you will find this information useful and practical. Ellen?
Rita, I'm so glad to be back with you presenting the second session of Care Forum 2021. I want to second your welcome to all of the participants at this session before we delve into this very exciting area. What we're going to be discussing today is really about transforming healthcare so that it becomes routine to include the caregiver as an integral and necessary part of the healthcare team, or as Rita said, this unit of care. For this talk, we're going to be calling the patient or the loved one the care recipient. And as we discuss this unit of care model, we're going to discuss the many benefits to both the caregiver and the care recipient, but also the many barriers to this type of care. And we're going to stop at various points to answer your questions, and we'll also leave time at the end for questions. But before we get started, we really want to highlight a message about caregiving during the pandemic. Next slide, please. Or start the slide deck, please. And next slide.
Can you see that okay?
Thank you, Ellen. I think any topic about caregiving and has to include the pandemic. We have gone through these months and months of excruciating angst as well as resilience. The financial, emotional, and physical strain for caregivers has been exacerbated by COVID-19. And I just want to share this wonderful quote by Dr. Whitting, the CEO of National Association of Caregiving. It's interesting to read this. The pandemic has pulled back the curtain and brought to the forefront issues that caregivers are having. So it has been a lot, Ellen.
And the next slide, we want to go over the objectives of specific objectives of this session. Next slide, please. So first of all, we want you to understand the new role of the caregiver in healthcare, this unit of care that we're talking about.
Next would be to learn to advocate for this unit of care. So patient care and caregiver health is better. We believe that to be a very big objective today.
And finally, how to self-assess the burden on yourself as a caregiver, and then to be able to communicate that to your health provider. Next slide, please.
So Ellen and I just love this picture. This was given to us by a wonderful colleague, and we wanted this to be symbolic of a new trend in healthcare, which recognizes the important role of the caregiver. Ellen and I have been working in this field for so long, trying to advocate and lobby for this.
Or as we like to say, a new dawn in healthcare. Next slide, please.
So this talk is really designed for the informal caregiver. Who is the informal caregiver? Can be the family member, a daughter, son, spouse, partner, friend, neighbor, anyone who is and feels responsible for the care recipient. The care recipient may need a caregiver because of injury, mobility or memory issues, illness, or just chronic conditions that make everyday tasks more challenging. We all know informal care can be substantial in scope, intensity, and duration. Most are rushed into this role and do not recognize or understand the consequences. Ellen, I often talk about the quote I share with all my caregivers. It takes us 9 months to prepare for a baby and get every aspect of care ready. It literally takes us 9 minutes to become a caregiver. Research in this field shows that the suddenness about becoming a caregiver or the crisis element in this field makes it so hard.
Rita, I love your quote about that it only takes 9 minutes to become a caregiver. It can be such a sudden transition. While both of us recognize the value of paid caregivers, today we are focusing on informal caregivers that you described who provide this care without any pay. It is estimated that there are about 53 million caregivers, or about 20% of the adult population, who provide unpaid care. This caregiving is significant and vital to the functioning of our healthcare system. It includes so many aspects, yet many in the healthcare field take it for granted. Care may include supervision, physical, emotional, social, and/or financial support. Studies have shown that when a family member is involved in care, the care recipient does better, but the caregiver may experience more stress. Next slide, please. That 53 million figure is important to note, and the value of their unpaid work has been estimated at $257 billion. Most caregivers are women who handle time-consuming and difficult tasks like personal care. But male caregivers are becoming much more involved in tasks, managing finances, arranging care, as well as direct personal care.
Agree, Ellen. So we will spend a little bit of time in discussing the types of informal caregivers. Many times the boundaries are not clear, and responsibilities often get taken up by more than 3 or even 4, sometimes 2 people. The primary caregiver is the one who assumes the greatest responsibility, but that primary caregiver may not be the healthcare agent. And then I'd like to illustrate this with a case study. I'm working with an adult children of an older adult who lives alone, and the power of attorney for health is with the daughter, but the power of attorney for finance is with the son who lives in another state, so long distance. The daughter accompanies the parent to all appointments, manages the complex medication matters, contacts for all the professional caregivers. However, in this instance, the son, who is again the financial power of attorney plus his long distance, does like to assume responsibilities, but is not the healthcare agent. These areas, as you and I know, Ellen, can become blurred and can lead to conflict and stress. Both of these children have great affection and great responsibility, but the health system sometimes does not recognize nor understand these kind of issues that can actually impact the care coordination of the care recipient. Don't you agree, Ellen? I think you do. So now we move on to the discussion of this new and exciting model of healthcare that is emerging, and we are actually observing it. Next slide, please.
I agree, Rita. This new model of healthcare is exciting. And we define the unit of care as when caregivers are fully integrated into the healthcare team. Healthcare is definitely moving towards this model, although we're not completely there. We know, and studies have shown, that when caregivers are an integral part of patient care and in a central role, there's better quality of care and increased safety. Family caregivers have regular interactions with a care recipient and are thereby better able to monitor changes of health than the health provider. Including the caregiver in the health team has been shown to increase the confidence and mastery of the caregiver, leading to better quality of life and their own better mental health.
Exactly, Ellen. I mean, I think it is so important that this recognition of this unit by providers and health system, as you just said, is so important. For this model to work, however, there needs to be good communication, collaboration, and coordination of care between the caregiver and healthcare team. You know, as Paula had said, we talked in the hospital setting so many times, we see this during discharge planning. There are so many benefits to this, but unfortunately, there are significant barriers to communication with the healthcare team and the coordination of care. Ellen and I are both observing these in our daily practice and how they impact the care for the care recipient. The next slide depicts the barriers we face. Next slide, please.
So unfortunately, while we both think this model of care is essential and important, there are many barriers to this unit of care. First, caregivers need to be identified. It's important to always identify yourself as a caregiver and make sure that that information is in the medical record. Caregiver information is often missing from the medical record, and there's usually only one space for one caregiver, even though there may be multiple caregivers involved. The hope is that asking a patient's permission to speak to family members will become part of routine care. One way to do this is for the health provider to simply ask, do you have someone, to ask the care recipient, do you have someone that looks after you or cares for you, or who you're in regular contact with, who does things for you? And then after finding out that information, the healthcare provider needs to make sure that this person, the caregiver, has the necessary information, education, and support. Of course, it goes without saying that the care recipient should always be able to decide how much information should be shared with family members.
Thank you for that. The next barrier is not enough education or inclusion of caregivers. And again, this is something that we observe often. Education for caregivers, as you all know, is crucial for them to better understand and carry out caregiver responsibilities and tasks. Information and education on diagnosis, the treatment plan, the path of the illness, these are what we caregivers need. For example, can I expect a sudden change in the care recipient's illness, or will it be gradual? Having this information can lessen caregiver anxiety and help us. I have experienced this, Ellen, time and time again with my father-in-law's illness in and out of the hospital setting. More information makes it so much easier to handle.
Rita, you're so right. Another example is when the care recipient has congestive heart failure. And just knowing that the person may be stable for a long period of time and then have an exacerbation or a sudden decline and end up in the hospital and then maybe stable again for a long period of time. Again, this information can be really helpful to know what to expect. But a third barrier that I want to talk about is problems in communication, which frequently occur between the healthcare providers and the caregivers and care recipient. Unfortunately, doctors often use medical terms or doctor speak when talking to patients and caregivers who may be reluctant to ask questions. There may be little time set aside for this necessary communication, little time for the healthcare providers to interact with caregivers and answer their questions. And unfortunately, there's often little reimbursement for physicians to spend time with caregivers. The good news is that physician reimbursement models are starting to change to allow more time for this. It used to be that healthcare providers were only paid for the actual time they spent with the care recipient. And even if they spent hours talking to caregivers, there was no reimbursement. But as I said, this is starting to change.
Ellen, that is such an important topic. And it's so, because I have been in the situation where I've talked about this, and I know that we've been lobbying for this, that medical health providers are reimbursed for that extra time. The next one that we believe is a barrier, and here is where we are empowering you to advocate for all of this, is that the health providers need to know about the caregiver health. So you need to speak up. Health providers should not only learn about the daily life of the care recipient, but also you as the caregiver. In 2016, something powerful happened. CDC stated that due to many factors, family caregivers' health and well-being was at risk. This was the first time something like this happened. And then in 2020, AARP and the National Alliance for Caregiving nationally reported that family caregivers were in worse health than they were 5 years ago. Such important data. Failure of the health provider to address caregiver stress and fatigue can put the care recipient at risk also.
And another barrier can be lack of access to of the caregiver to the care recipient's medical information. We mentioned in an earlier talk about increasing use of the shared access feature on the health portal, which will allow the caregiver to see information in the medical record. Not having this access can limit communication. So again, it's important to advocate either the care recipient, allowing caregivers to have information, and caregivers to ask if it's possible. There may be some privacy restrictions from HIPAA, but you can certainly always advocate for increased access.
And this new model, Ellen, is going to require policy changes. Some of us are working on that national level, and will require further input from Medicare. In addition to reimbursing health providers for spending time with caregivers, there will also need to be more robust funding for programs that provide active support to caregivers. Next slide, please. So Ellen, as we leave this important topic and move on to the next topic, we just want our audience to know about some of the national initiatives so they are better informed. Some of these policies are at the state and federal level, but the health system is recognizing, still slow to change, but it is emerging.
And some of you may be aware about these exciting initiatives. the CARE Act, or Caregiver Advise, Record, Enable Act, is a state law. It's currently, I believe, has been passed in 40 states. So not the whole country, but certainly California is included. And this requires hospitals to identify caregivers and record the caregiver information in the medical record and include caregivers in discharge planning. The caregiver is supposed to be provided instructions about the medical tasks that the caregiver will need to assume on discharge. Now, this is only in the hospital setting, not in a clinic or doctor's office. But at the time of hospital discharge, you can advocate for being part of the discharge plan, and make sure you get the information you need that will allow for a safe discharge home. The RAISE Family Caregivers Act of 2018 is a federal act. In January of 2018, it established a federal council to develop a national strategy and plan to support family caregivers. Now, it met for the first time in 2019, but has met 7 times since, with the most recent meeting just last month. It's part of a broad national effort to improve the lives of caregivers. And they're coming out with sort of advisory actions about money being provided to support family caregivers.
That is great. And then, of course, the last sentence on the slide, which is Medicare Advantage. The supplemental benefit was expanded in 2019 to cover direct support to family caregivers. But only 13% of the plans are offering this support right now. We have a long way to go. However, I know that personally, I've been working with a couple of Medicare Advantage, platforms to say that what are the critical areas where we can help support caregivers, because remember, this goes a long way to improve caregiver health and the care recipients' health and outcomes. We have a long way to go.
I remember, Rita, being very excited when I first heard that Medicare Advantage was going to cover this support to family caregivers. So it is disappointing to know that only 13% of the plans actually do provide this coverage. There needs to be, I think, more pressure on these Medicare Advantage programs to provide that support.
Remember, Ellen, if you look at our journey, our work history, so much of this was not there. It requires active caregivers to voice. It requires professionals like us and others. So I think we are moving along, but I think the goal of our talk today was to empower the audience to ask these questions and also, hopefully move the system forward. So
yeah. Next slide. We thought that this would be a good time. There's been a lot of information that we presented to just see if there are any questions in the chat or any questions that have come up. So next slide, please. Oh, sorry. I thought there was a question slide, so we'll go back. But so Paula, are there any questions?
Am I on? I don't know if I'm still
yes,
muted.
you are.
Okay, so I'm very familiar with everything you're talking about because, as Rita knows, I've lived it too. I've been a discharge planning social worker in hospitals, nursing homes, emergency rooms, ICUs, all the places none of us ever want to be. I've been there, and so have the two of you. So I think the first thing, let's go back a little bit to the barrier to communication. Can you comment both on the difference between having informed consent and access to a discussion with the doctors versus having the durable power of attorney for healthcare decision making? Because I always suggest you kind of have to have both depending upon the situation that's present. And I think people are confused about who needs to have what.
So,
Ellen, you want to take that?
it can be confusing. So having access, requires somebody, anyone in the healthcare field, to ask the care recipient, can I share this information with someone? And if they verbally say yes, that information can be shared. A more formal process, in case they can't get the verbal okay from the care recipient, is to have durable power of attorney for healthcare. the healthcare community is very familiar with that. They know if you have that healthcare proxy, they can share everything. It's a more formal level of access. But care recipients, without having that, even if there is no durable attorney, power of attorney for healthcare, can verbally okay shared information. And just an example, my mother-in-law was in the hospital just a few weeks ago, and I, as the only physician in the family, would call in, and they didn't have the healthcare information. I'm not the healthcare proxy, but they were able to go into her room. She would say, "Oh, sure, share the information with my daughter-in-law," and they were able to share up-to-date information of what's going on. So I don't know if that's helpful. There's a difference between a formal process, obtaining durable power of attorney for healthcare, and then you are officially, you can call in, and that you are the person that they are legally obligated to share information with. And if the person can't give their okay, you are listed in this document, as opposed to a more informal process of just saying, it's fine with me, that can be verbal, can be written, you can share this information.
Okay, we have a few more questions popping up, but I want to go back to the informed consent for everybody to realize that that's the most simple thing to do at the start of any process where you become a loved one's caregiver, and that person's alert and they can sign in their medical records while they're still kind of in the outpatient world, or once they are inpatient too. But as long as they have it documented in their chart that they're giving you informed consent, that's going to make everybody's life easier, including all the changes of shift.
That goes back to where advocating to make it part of just routine care, that anytime somebody becomes part of the system, the healthcare provider just asks them, is there anybody who I can be sharing information with? So it's almost flipping it. Yes, until that becomes part of routine care, you maybe need to sign this informed consent, but everybody should be asked, are there people that we should be sharing this? Somebody who's involved in your care, a family member. And that's what we're advocating for, that the healthcare system makes that part routinely. Everyone gets asked that question.
That's wonderful. But I know so many people in my caregiver groups who we simply say, for instance, like at Palo Alto Medical Foundation, go to the main desk to the left of the entrance where the administrative staff is sitting, and they will print out an informed consent so that you and the loved one really just needs to sign it if they're alert, and then put it in the chart, and there you go, you have it. And once that's there, then you can set up access to the account. Okay, so here's a question. It says, I'm the wife of a husband who has Alzheimer's. Would there be any problem with sharing all the information with me?
So does she have, either was there informed consent signed before the person's Alzheimer's developed where he couldn't, or is she does she have durable power of attorney for healthcare?
It doesn't say, but from reading this, I'm assuming that a lot of people do assume that if somebody is diagnosed with Alzheimer's or dementia, that automatically means they lack capacity, and that's just not true. They have to be evaluated, and that's a separate evaluation from a diagnosis of Alzheimer's or dementia, which might be early stage, and they can still be driving or have capacity. So you have to have a capacity evaluation for somebody who has cognitive change to really understand where they're at in the decline, the cognitive decline, and then where you come in. Okay, so she's giving us more information now. So he's got a lot of complicated problems. He's in Napa, she's in Palo Alto. And wait a moment, let me see.
This is such a big topic, and I think this is what Ellen and I are covering in the next topic, because when you look at cognitive incapacity and you have not had those documents signed or those instructions given, then it's a different process. And I think go into a greater detail, because this is something which we are encountering very often.
Right, we're going to have a session on dementia care. So if somebody lacks capacity, there's definite things that has to be done legally for the caregiver to step into that role. But if there's an emergency, of course, they're going to ask you, they will turn to the caregiver. All right, so there are some longer questions here.
So we could take that the next time, maybe, Ellen, and proceed.
Yeah, no, I on the next unit, which is caregiving within dementia, I think I'm going to be talking a lot about capacity, and I think both of us are going to talk about just some of the more difficulties caregivers experience when your loved one or care recipient has dementia.
Okay, so there's another question about hiring agency caregivers who have a 4-hour minimum and are expensive, and there's somebody who wants to look at caregiving resources. You know, I'm going to suggest to you that you call me here at Avenidas Care Partners at Avenidas, the 650-289-5438 phone number, because that's something that I would need to talk to you offline about rather than go into how to help you find caregivers right here now. So there's another question. My husband has just started palliative care. What should I expect my role to be as a caregiver within this service if her husband is now in palliative care? How does she team with the palliative care social worker, doctor?
So I'm assuming it's outpatient palliative care, which is a wonderful service, which should be providing a whole extra level of support in caring for her husband, who I'm assuming has a serious illness. Now, the palliative care team won't be providing hands-on caregiving, so it doesn't lessen that the need for if your husband needs help with personal care. But in terms of supporting her as she goes through the journey, if there are emotional needs, psychosocial needs, support, as well as giving her that, as we said, that knowledge, knowing what to expect. The nurse, the physician should be able to provide her with information about what to expect as her husband proceeds with his illness. So they're there to provide support, but they don't provide sort of hands-on personal care.
And I'd like to interject here to the member who asked this question, because I think for about almost a year, I was the caregiver for my father-in-law who was in palliative care. And I felt that, just like you said, Ellen, in spite of my knowledge in geriatrics and palliative care, they were so helpful at every stage that they would identify the problem. They would talk about communication, letting me know what to expect. So I think it is important to also know, as a caregiver, to ask those questions, to reach out, to be told to be included. So I think, you know, and again, as Paula said, if there are any specific questions, please direct them to Paula. We are also happy to answer after the session is over. Paula can share those questions with us.
Yeah, I can't recommend a palliative care program enough, because when you're dealing with serious illness, there's so much of the unknown and the loss, and getting a team to come to your home or to go to they also have clinics to provide that extra level of support can just lighten the load and lessen the stress of caregiving.
And the palliative care teams also will come in as people are just in decline and be of support to the caregiver, correct? That
we lost some of you question, but palliative care is for people with serious illness. They don't need, they're not hospice, they're not near, they don't have to be near the end of life.
right.
Even just at the diagnosis of serious illness, and they do provide support to the caregivers.
Okay.
Palliative care has recognized this unit of care from the very beginning, that caregivers are essential to the health of the care recipient and the loved one.
There's another question. What kind of caregiver support is proposed in Medicare Senior Advantage?
So let me answer that. So I think that it depends exactly on the particular Medicare Advantage plan that is available. We are working at more of a design level to include caregiver support, such as, you know, how they recommend the extra benefits that are coming to care recipients. But this would include to define who is your caregiver, the primary caregiver, what information do they need, how can we support them? So again, Paula, this would be important to know which particular Medicare plan they are part of, and to ask this question of the person who is in charge of that plan. So typically what I do is I would ask my caregiver to say, please go ahead, contact the person who is providing care for the care recipient and ask them, are there any special programs designed? Some of these could be just giving them resources, giving them information, opening them up to support groups. It varies. We are still in the beginning stages with Medicare Advantage, but it is moving along positive lines.
Okay.
We resumed slide, Paula.
There was just, I think Karen, there's a question from Karen, and I'm going to ask this. I think what she wants more specific information on palliative care, but I think the question might be, what would be the signs and symptoms of when you should say, when should I seek palliative care?
Got it. Okay, so I'm going to give a brief answer, but we actually are doing a whole session on palliative care
Okay.
because there is a lot involved. I believe that's session 5, so not until August. So I don't want people waiting until then. So and I think there was another question about where do you get palliative care?
Right.
So unfortunately, not everyone is eligible. There isn't outpatient-based palliative care throughout the country. Certain healthcare systems do provide it because there's been clear benefit to having home palliative care. So Palo Alto Medical Foundation has a outpatient palliative care. Kaiser has an outpatient palliative care. UCSF up in San Francisco has outpatient palliative care. And a number of hospice programs in the area have set up as sort of an other initiative, home-based palliative care programs as well. So there are various ways to get it. If you're in a certain health system, you can request it. You can ask your primary care provider to make a referral to home-based palliative care within the Kaiser or PAMF system. And so when to get it? I mean, if somebody is going back and forth to the doctors a lot, if there has been, you're dealing with serious illness, and it can be any illness, it can be Alzheimer's, it can be ALS, it can be congestive heart failure, COPD, any type of cancer. And it's not at the point, necessarily where people are recommending hospice, where it's the final few months, but it can be years that you are dealing with a serious illness. You are needing a lot of support from the healthcare system. You can get a referral to palliative care. Now, each program may have certain requirements. At one point, they were so much in demand. PAMF in the early days was saying they had to determine you may have only had a year or so left, but more and more programs are getting rid of that year or so and are saying, no, we really need to support families and caregivers when their loved one has serious illness.
So Paula, I'm going to continue just in
Sure.
for
Thank
time.
you.
So I think, as I said, we will have another session on palliative care and other advanced care planning, and also on dementia care. So I just want to go back to an important matter we just stated, that the health provider really needs to learn about the caregiver. But equally important is the caregiver's own perception of themselves. And I think most of us who call ourselves caregivers, lack this awareness because we are so busy. I recall my years of active caregiving with my parents, my in-laws, and I never stopped to catch my breath or to assess how I was feeling. Ellen, you and I have always believed in caregiver self-assessment. In fact, when I start working with a caregiver, the first thing I do is use a standard scale for self-assessment and ask them, how do you assess yourself? And this is a scale we will discuss with you. So, Kat, next slide, please.
Yes, caregiving experiences are so complex and different for each individual. So a comprehensive self-assessment should include both positive and negative aspects of caregiving and emotional well-being, including stress and caregiver burden. And we recommend a self-rating scale, which will really look at the specific problems, needs, and strengths, as well as resources. We're going to discuss one that's developed by the AMA, or the American Medical Association, with geriatric colleagues. We are going to make this scale available to all the participants on this session. We tried showing it on an actual slide, but it was too small and too blurry. But I'm going to go over some of the questions on the scale. So next slide, please. So this self-assessment questionnaire is really looking at how are you doing and asking specific yes or no questions. And this is the instructions on this specific scale. And they want to make sure that sometimes you can get so busy caring for your loved one that you're not paying attention to your own well-being and your own health. So next slide, and these are some of the specific questions on this one example of a self-assessment. And they're sort of yes and no answers, yes or no boxes to check off. I felt completely overwhelmed. I had trouble keeping my mind on what I was doing. I felt useful and needed. I have been satisfied with the support my family has given me. I found my relatives' living situation to be inconvenient or a barrier to care. So this is just a simple example of the many questions on the self-assessment. There is a scoring that is included with the self-assessment, and it's on the scale. And as I said, a copy of the full self-assessment scale will be available through Avenidas to everybody on this call. If after doing the self-assessment, a caregiver has concerns, I usually advise them to speak to their healthcare provider or their primary care provider, and sharing concerns such as lack of focus, if they're missing health appointments, any irritability, sadness, grieving are very important. During clinic visits, the healthcare provider should be taking the time to explore the caregiver's well-being as well. And these are some questions we encourage the healthcare provider to be asking during clinic visits. And these are questions that the healthcare provider would be asking caregivers, which we feel should be part of their health assessment. These are one question: do you see a doctor for your health needs? 2, do you have any help caring for your loved one? 3, who gives you support? And finally, just even the statement, many family members find caregiving stressful. Can you tell me how you are dealing with it? So I'm not sure if health providers are asking these questions, but certainly the AMA and health associations are recommending this shift to family-centered care and making this part of caregivers' health assessment. If the health provider is concerned about their patient's well-being, the next step might be to refer the caregiver to a local support group, or if more intervention is needed, a mental health therapist, such as a counselor, psychologist, possibly a psychiatrist. Rita, you're writing a book on caregiving and the support, and I wanted you, with a number of Stanford authors, and I wanted you to share some of your helpful insights from the book.
Thank you, Ellen. And I think I just saw a question on the chat line saying it is so hard for caregivers to take the time for themselves. And I think you and I, Ellen, we have been caregivers in our personal lives, so we recognize. But the whole goal for this talk or any other is to say that you are important. You need to stop and self-assess and get the help. So this particular book with 4 of our Stanford colleagues is one which we believe is a bit of a pioneer work. And what it is trying to do is telling caregivers to talk to their health providers, but also to seek help. So which is support groups, any other kind of therapy, and there are multiple kinds available. Another important goal of this book is to equip doctors and therapists about specific knowledge of the care recipient's journey. What can happen during this whole illness trajectory, and the varieties of issues that a caregiver can experience. For example, if suddenly, you are a caregiver and your loved one is going in and out of the emergency room, what kind of stress are you going through? Or you are looking for a placement for your loved one. How do you deal with that guilt? What do you do for resources? So the book is trying to show therapists and psychologists about these kind of data. But all of this, again, starts with self-awareness, self-assessment, seeking help. And finally, Ellen, I want to say that in terms of therapies, there are so many kinds: mindfulness-based stress reduction, different kinds of counseling, psychotherapy, cognitive behavioral therapy, psychoeducation. All of these can be discussed with the health provider. So I want to take a minute, Ellen, and just look back as to what we have talked to move to the last topic. So far we have discussed the unit of care that we hope will transform healthcare. We have talked about the barriers to this unit of care, how we can advocate for an increased role for caregivers. We have next talked about how important it is for a caregiver to do self-assessment, understand and recognize their own strengths and weaknesses. The last would be some tips for improving caregiver resilience. The next slide, please.
Yes, we really want to leave you with some tips for helping caregiver strength or resilience. And I strongly believe, Rita, that knowledge is power. With knowledge comes less fear of the unknown. The health provider may give this information, but the caregiver can certainly ask for what to expect. For example, what signs should I be looking for? Or what are some of the signs of decline I should be expecting? Studies have shown that when caregivers are given information about the care recipient's illness and training on some of the caregiver tasks, as well as support, both the caregiver and the care recipient have a better quality of life. And I certainly know this through my work in hospice. Is one of the biggest gifts that the hospice team could provide the family was information of what to expect as the days and weeks went on. So I can't highlight enough about, hopefully doctors or health providers are giving this information, but ask questions about the illness. The more information, if you want it. There are some people who say, I don't want to know what, but for a vast majority of people, having this information does lessen their anxiety.
Thank you, Ellen. I think I want to definitely admit that in my years of work with families and caregivers, and remember when I say the informal caregiver, I mean the family member, the adult daughter or the son or the spouse. I think I have so much respect for them because they are juggling their own lives, their own work, their health, and then coping or dealing with the care recipient's different needs. So self-assessment is really important. Supporting caregivers with early identification of their own health and emotional challenges is important. And I think caregivers learning about how to identify triggers. So as caregivers, Ellen, we go through all these emotions, and I think so much has been written about them, about burden, about anger, guilt, just exhaustion, that I feel it is really important to recognize triggers. And what are these triggers? A change in your own health and circumstance. So for example, when I was dealing with my parents or my in-laws, I found that if there was a change in my own health, in my own circumstance, it was so much more difficult. So to be able to recognize those triggers and even admit them is important. Some of those triggers in care recipients can be sudden decline, constant ER or hospitalizations, or being moved from a home to a skilled nursing facilities, or even just dealing with the health system of getting appointments, diagnostics. All of these can present as triggers. So much can be achieved by starting with self-assessment, becoming aware, reaching out for help, and then, understanding what other interventions or support is out there. I'm not saying it is easy, but we have to make the effort for the health of the caregiver. So the final and the next slide, please.
So in summary, we both strongly believe that this unit of care with the caregiver as an integral part of the system, caregivers need to be part of the conversation and included in decision-making, listed in the medical records, and provided with the necessary information and education that allows them to be good caregivers. And Rita.
And the great importance, again, as I said, of self-assessment, seeking help, proactive planning. And then I also, think about the importance of just sitting down and discussing these areas with either your family members or, of course, with health providers, because having a plan and making sure that you are taking care of yourself. I know we repeat this again and again, but it is important to do that. These critical conversations are really important. So as we end this particular topic, we are, of course, we would like to mention the next session and also take questions. So the next slide, please. Oh, this is the quote that Ellen and I love. Never believe that a few caring people can't change the world. For indeed, that's all who ever have. And I think if you take the backdrop of our talk today, which is moving towards a new unit of care, recognizing caregivers, self-assessment, asking medical providers to ask more questions, we are in a way trying to change a system. Don't you agree, Ellen?
Definitely, Rita. And we're open to, I see that there are a lot of questions, I believe, in the chat. So we're available for questions.
I think, can you hear me? So I think one question is to go back to a little bit about resources and help. Can you possibly, Rita, this might be for you, describe a difference between when you would want just kind of generic emotional support and when you would really need therapeutic support?
So I think this again is an important question. I get asked that a lot, Paula. I think that when the circumstances of taking care of your care recipient really starts interfering, like if you look at some of the questions that Ellen read, where you're having difficulty focus or it's just a constant burden with you. Because if you think about it, I look upon this as sort of a journey. So when we start intersecting with the health system, so for example, if the care recipient, I'm going to give an example and say it's a husband, and they're beginning to start needing help, and there are small things that are emerging. You may just need emotional help in figuring out how to go about the diagnostics, how to go about good appointments, help in that. And that can be given by another family member. It can just mean coming to a support group like you run, Paula, or even speaking to your physician. I think what I observed in my day-to-day practice, and Ellen, you can step in as well, is when it becomes constant, when it becomes the underlying factor of your day-to-day existence, when you're every day juggling with either the care recipient's care, your own life, that's when things become a little blurry. And that's when you probably need to take the time, visit your physician, look at your own screening, find out where you are with your health appointments. Why are you feeling? What are you feeling? Does it have a medical basis? Does it have an emotional basis? Speaking to psychologists. So it's really, Paula, it's a continuum. It goes from mild to severe. And I, in fact, have a slide that I use to talk to caregivers when I sort of show them the wellness to illness kind of a continuum. I don't have it with me right now, but Ellen, could you add to something? Could you add to what I just said?
I mean, only to just sort of emphasize and support what you said. It's when it becomes pervasive, interfering with your own daily life and function, and you can't function, you clearly need much more than emotional support. but need to see a therapist. And then I love your, your continuum, but because in the beginning, where it's mild and you're just starting and you becoming part of a support group, talking to other people going through the same thing, finding out what works for them can be really helpful. But as you go along the continuum and where it's taking over your own life as a caregiver, becoming much more pervasive, interrupting your functioning as what you're doing, when you're not a caregiver, is when you need just more than emotional support.
And Ellen, I just want to add one more. I mean, I'm just talking about because what I learned from my care recipients, my patients, and my caregivers, that's what's defining us to even write this book. So I want to say that I acknowledge what a caregiver is telling me. And I often tell them that, do you really have to feel this intensity? Do you have to do this yourself? Is there someone else you can count on? I think most of us find it really hard to delegate responsibilities. Most of us find it a sense of guilt. I should be doing everything. And that's a conversation to be had with either your health provider, with your psychologist, with even a good friend to say, do I need to take on everything? Can I separate some of these out? Because it is constant. I mean, think about the details that can happen from an appointment, from just a blood test, from reading those, from moving towards care. And of course, dealing with the professional caregivers, which are the paid caregivers, trying to coach them, trying to train them. And if they're coming for a little bit of time, what do you do when they leave? So all of these questions are important. Please feel free to ask, even if you don't have the time now, ask Paula. We are happy to help even after this session.
Okay. We do have some more questions popping in, so I'm going to kind of go back up and read them, but as I'm getting organized to do that, I think it'd be good to talk a little bit and just point out, I see these as signs when people do need more therapeutic help. If they're perseverating, have overwhelming anxiety, panic, and hypervigilance throughout the day so that nothing else in life sinks in, no joy, no happiness, and they're just caregiving. I call it complicated caregiving, like we talk about complicated grief, when it just takes over your life. So,
I mean, Paula, what you're talking about is almost the clinical definition of depression, where it's taking over your life. It's becoming so pervasive that you can't do anything else. And definitely at that point is a time to seek professional help. So totally agree with what you said. I mean, that this pervasive, persistent, you just can't get out of this situation that you're in. Because aside, other times people who are doing the caregiving are very busy, but they might still be functioning and going to work and doing everything, and it hasn't taken over their life. But what you described is where the caregiving has taken over everything, and you really almost can't function in any of your other roles.
Okay, so here's a very good question about the caregiver who's waiting in an emergency room. And this comment is by somebody I know who's been a lot to emergency rooms. So how can a caregiver, when they're in the emergency room, be supported? What should they do in order to kind of announce that they're there and ask for support? This person is saying that she has felt support for her has been non-existent when waiting in an emergency room.
Well, just to say during COVID, this has been magnified 1,000% because so many of the times they don't even let caregivers into the emergency room. So, I mean, I can give an answer when some of those rules are relaxed because, and there certainly is a social worker in the emergency room that is supposed to help with some discharge planning. More and more emergency rooms are having palliative care be present even in the emergency room to help with the discharge home if the person is going home from the emergency room. But in this last year, it's been extremely isolating for both patients and caregivers because the person couldn't even step inside very often. So if you're not allowed in, but still if the emergency room is going to discharge your loved one, you need to definitely ask/demand that someone, social worker, the physician speak to you about what is going to be required if this person is going home. because I think the emergency room is one of the sort of the last places where they're providing some of this extra support. Rita, what do you think?
I think so, Ellen, having 20 years of my life in a hospital setting, and many times I was in the emergency room just because of the fact that the older adults would come back again and again because of that's the, we talk about readmissions. So somebody comes back into the emergency room, there's a distraught caregiver inside right there. And that was, I think, one of the reasons our program was developed to provide that support. Now, I want to go back to the question that was asked, which is not during COVID, but obviously probably before that. How do you find support in the emergency room? So I think that in that case, based on what is going on, if you are the caregiver who has just transported a loved one because of something that happened, and you really need to set up a system whereby the loved one needs more support, or you don't know what's going on medically, I think it is important before you get discharged to say, is it possible for me to talk to the medical team? Is there a social worker that I can speak with? This is what I teach my caregivers to say. Have a conversation with the medical team. Yes, that medical team in the emergency room is just looking at the patient for that particular time, but at least they can tell you that this happened, maybe this needs to be followed up, this needs to be a referral to something else. And if the social work department, somebody can come out and say, what are your current problems? What is it that you need right now? Do you need resources for transportation? Do you need resources for a caregiver? Do you need resources for a skilled nursing? So we have worked on this field because we know that caregivers are so fragile in the emergency room. And I think talking to the medical team, talking to the social worker, but it does not end there. It starts there. Moving on next, taking the time to go with the loved one to the PCP's office or the primary care doctor's office and say, this is what happened in the emergency room. Can we talk about what to do next or what to expect next? So I'm sorry, it's a long-winded answer, but honestly, at every stage, you're needing this support.
And you're right that emergency rooms have not always been good about providing that support. And it sometimes will take the caregiver to ask for it or advocate for it, saying, I need to speak to the social worker. There is always a social worker assigned to the emergency room. And they're starting to become more aware of that this is important because they don't want people coming back to the emergency room. Hospitals get penalized if people are coming back too frequently. So they're starting to put a few more programs in place. But unfortunately, it does sometimes take the caregiver to speak up and say, I need to speak to someone. And whether it's a social worker or the physician or the nurse that's in there, that to make sure that you have that information and get some support before you were bringing somebody back home.
And I would like the last slide on, Paula, just to be reminding our audience about the next session.
Okay. There was just a few more questions. This was again about informed consent. So this is from Carl, who's trying to get more of the family involved with having access to information. And so he's observing that it wouldn't be through an advance directive, which is about treatment preferences, but more than likely with an informed consent for everybody to have access. And I just emailed him back and said, yeah, that would make the most sense if he's trying to create some sort of access for family. But there are also, just so folks know, there are these online websites you can create. Caring Bridges is one, so that you as a caregiver with the information can just post as you wish and give everybody access to your website called Caring Bridges. Google them to give out information rather than sending out many emails, especially if somebody's having a prolonged hospital or rehab stay. People have set up Caring Bridges websites.
Right. And I usually recommend, I think Caring Bridges and those forums are a great way to share information, shared access with a health portal. Because I usually say the family should designate one person who actually calls into the hospital so that you don't have various family members calling and asking to speak to the physicians at all different times. That if you do designate the contact person with the healthcare team, that can be a better way to get the most information. And then that person can then share the information, whether it's Caring Bridges or however the family chooses to share.
I'm going to combine two questions. So Rita, somebody wants to know about, your book, and will it be for caregivers in general, or is it for professionals? And then here's another question that you might want to think about for putting this type of information in your book. But so somebody also wants to know if there's any kind of informal online website where caregivers can register and just among themselves share tips with each other and provide basic or practical help. And the only person I thought of is a woman named Denise Brown, who I think has a peer support caregiving organization. I've seen her on LinkedIn. So I've told this person. But so Rita, let's just get to a little bit more to your book. So people are curious about who is it for?
So this book is really, well, it was asked of us to write for medical providers, for equipping psychologists and psychiatrists and other clinical psychologists for, learning about the variety of problems that a caregiver can face. So it really started from that forum whereby we found that many people do not know what all a caregiver can go through. I mean, those of us who navigated a loved one, whether it's congestive heart failure or dementia or cancer, there are so many parts to it. So Paula, to start with, it was really about compiling all the different bits of information for mental health providers to better serve caregivers. So it's really a professional book for, clinical psychologists and psychiatrists and so on. But in that book is also listed the different emotions caregivers go through, the different aspects of, the different encounters they have during this whole continuum of care. So it does have a two-part purpose. And the second question that you asked me was about an informal support group. So
Online.
Online, yes. So I recently, was a part of a group which had a lot of wonderful people on it. It's called the SHFC. And what I can do is I can email you that link. It's the only national program I know where there's an online system of getting caregivers. They have it's a new entity. They have about 2,000 caregivers. They're divided into different groups. It's really wonderful. I will send you that link. That's the one thing I know of. And Ellen, in case you know any, but I will research this and get back to you so you can mail it to the audience.
I see Julie's question as well as a site providing basic practical information from professionals. And one of the best sites, Family Caregiving Alliance.
Yes.
And I don't know if you can put that in the chat, Paula, but the Family Caregiving Alliance has wonderful webinars, information for professionals. They're really there to support caregivers. It's a national organization, but it has local branches as well.
And there is one more. It's called the Caregiver something network that I
yes, Caregiver Action Network, CAN.
Exactly.
Is another wonderful resource for caregivers.
It almost gives you tips about how to bathe a loved one, how all of the how-tos that you have. So again, we'll put all of this in a little email to you. You may already have it, Paula, but we'll be happy to send it to you.
Yeah. So before we all leave, Rita Ellen, post in the chat your email contacts as well, but I think that's on your slide, right? Everyone is going to receive a copy of the video, and I think your emails are on that first slide, correct?
I believe so.
Yeah, but we'll send it out. We'll post everything.
Yes. And we welcome anybody, if they want to send us a question, definitely.
Right. Okay. All right. So let's talk about next session.
Let me get the screen back up. Sorry.
And there was a great question about basic caregiving training. Rose's question. There are I've seen some various home care agencies and some hospices are doing some caregiving training. I wish there were more. One of the things we mentioned, the REACH Act, that this sort of federal commission, and one of the things they've proposed is actually having these basic caregiving training, because studies have shown when caregivers get this basic training, everyone does better. The care recipient does better, the caregiver feels better, their health is better. So there is a push to provide more of this basic training, but I don't know if Rita or Paula, are you aware of any others in the area? I know last year I saw a few home care agencies providing it. I don't know what currently is happening.
So, Ellen, a lot of physical therapists, occupational therapists, they will give you some hands-on care about the physical aspects of caregiving. And then I know that when there's a discharge packet, sometimes they will talk about guidelines and tips to deal with, say, Parkinson's or Alzheimer's, but important questions. I apologize, I don't think our contact information, is it possible for Kat to maybe just write it in our email addresses and just post it?
Yeah, we will post it. Everything will get posted on the website, and we are going to be sending everybody the video, so we'll get them the information too, and the caregiver assessment. I wouldn't.
Basic caregiver training, what the study I'm referring to is they actually had, in addition to these handouts that physical therapists or occupational therapists, they actually had in-person caregiver training sessions. And they found when people went, for these, they had telephone support and in-person training on how to do specific tasks as a caregiver. Both the care recipient and the caregiver did better, and the care recipient ended up in the hospital less. So there is this push, and I think it's coming out of the REACH work, that there be more funding for this type of training for caregivers. Unfortunately, there isn't very much available.
And I want to make a point, and I'll do it quickly. So there's professional agency caregivers who are certified trained, just like a certified nursing assistant is trained. So in order to work for an agency, all of them are trained to a certain degree on basic hands-on daily care, bathing, washing, feeding, showering, transferring, but complicated caregiving for somebody who's resistant or has dementia and is agitated, that's difficult and very specific. But the Alzheimer's Association and the Family Caregiver Alliance have many articles, very specific articles on, for instance, how to shower somebody. And they say, start with the feet, just warm water, the feet, work your way up, keep them dressed in something that can get wet. I mean, so there are those kinds of tips available. And again, I'm happy to help you find those, but you can always ask your doctor or a nurse assistant for these tips also, because they will be able to provide that to you. And about peer support, and what I see happening in my group, it's great to hear it. Everybody's an expert on something, but sometimes somebody's going to give you information about a medication their person is on, or a doctor their person has seen, and that person is very different than your person. So I'm going to strongly suggest that peer support is great, but you need to be smart and choose wisely, and always consult with your doctors.
Thank you, Paula, as a physician. Thank you for saying that. I mean, I think there's wonderful information that is shared at the support groups, but I would say before, yes, when it comes to medications and therapies, discuss it with your doctor.
And I think that one of the questions I saw, Paula, was that could we reach out to you if talking to us helps in terms of just assessing where you are and formulating your thoughts and ideas. I'm happy to take that. So thank you everybody who was available today. And I hope that you will take this information, advocate about it, talk about it to the other caregivers. So we are united, we move towards a new unit of care. And we do the best we can for our loved ones and for these wonderful caregivers we are working with. Thank you.
Yes.
As always, thank you, Kat. Thank you, Ellen.
Thank you, Ellen and Rita. And I want to also let everyone know that the care form is brought to us by the generosity of an anonymous donor. And we really wish to thank our donor for the ability and capacity to do this and to communicate with all of you and to create community, because ultimately we are creating community and connection here, which is very important among caregivers. So
thank you so much. Thank you.
All right, take care, everybody. Kat, you can take us away.